I think we often, we've had a lot of advancements, right, in how we utilize data or how much data is available to each one of us throughout the work that we do here at Western Tidewater. We went from back in the day with Avatar and some limited reporting functions that we were able to use and limited amount of information that you could report off of. And then we advanced into our time with Credible, and we've got a little bit more available through our business, our BI tool that we're able to use to create a different number of reports that can be emailed directly to somebody that you can go pull on your own, things like that. But oftentimes what I hear from people is, I don't really understand what I'm looking for. I don't know how to apply that to the work that I'm doing and things like that. And so really the point of today's training is to kind of help you think about better ways to use information to drive our treatment and to drive the way that we operate programming, and apply that to our day-to-day operations. And so as we go through here today, I'm going to try to be very interactive. Please feel free to unmute, ask me to stop and answer a question, or drop a question in the chat. I'm going to ask that David and Mitzi, guys, if you see something in the chat, if you could just pause me, and I'll do that because it's harder to monitor the chat while you're presenting, as everybody knows. That said, we'll dive into this. So why don't we start off with just what are business informatics? And Wikipedia, the source of all knowledge and truth in this day and age, says that business informatics is a discipline combining economics of digitization, business administration, information technology, and concepts of computer science, which sounds way too hard for me to remember. So I think we should take a little simpler approach here, and we should define business informatics as a way to harness the power of our electronic health record and other data sources to measure and improve treatment and financial outcomes for the work we do. So how do they fit into treatment? And some of you may be familiar with the cycle for quality improvement of plan, do, study, act. So I think that's an easy way for us to fit business informatics into the way that we look at our programming or we look at our treatment that we do. And as we've got a number of people that have done clinical work here, it's sometimes easiest to relate these to treatment services. So when we talk about plan, that's just treatment planning and assessment. You're putting together a plan that helps you to address a certain objective or goal. Do is your implementation. It's actually doing the work of what your plan says. So if my plan says I'm going to monitor the number of no-shows in my department, then my plan, or my actual doing of that, is going to be reviewing information based on the appointments that are seen over a period of time. Then we get into study. So that's the review of your results and the interpretation for meaning. That's where informatics come in and really help us to condense complex data or multiple rows of data, or things that just are overwhelming for most of our brains to look at, into results that we can later take action on. So you've heard the concept of a picture's worth 1,000 words, right? And so a picture often is what best represents it in our brains, so that we can take a meaningful action based off of a bunch of what we would call aggregate or across the board type of information. And then act is how we modify our plan based on that interpretation of those results. And so it's really not that complex of a process when you break it down into very simple steps. And we see a really good place for us to look at informatics in that studying phase and helping us to make determinations on how we'll take the next steps in our quality improvement. So here's your first opportunity to interact with me. Where do you guys see informatics or business data and interpretation? Where do you see these kind of things pop up in your day-to-day work?
Well, Brandon, for residential, for us, a lot of it would be surrounding bed days, a number of staff that are involved in our hours that we have that we're approved to bill for. It also can be captured in our hours that we're approved for our community integration and coaching, as well as our day support hours and how we're providing services around that, and trying to maximize staff versus hours approved for each individual.
Yeah, exactly, Debbie. So those are all like complex metrics that help you identify how well your program's working. So those different utilization reports and things like that. I think, yeah, absolutely. Everybody's shy, doesn't want to come, they don't want to come off mute. I'm going to encourage you guys, come off mute and share your comments that you've dropped in the chat.
Yeah, I was going to say they're pulling a lot into the chat now, Brandon. It took Debbie to start talking.
Well, I typed in the chat the productivity reports.
Mm-hmm. Yep.
Yeah, absolutely.
And I would say if you take it maybe a step farther when you're talking about metrics and informatics, if you take and try to set up your metrics as a leading metric, instead of waiting until all the P&Ls are done at the end of the quarter and stuff like that, you come up with targeted that you can follow on a daily, weekly basis. And that informatics would lead you to where we are there on this slide. And you'd already know it before you got there by the end of the month or quarter, in my view.
Yeah, so Kurt is a business finance informatics lead here, and he's helping us to do proactive projections and planning to try to hit those targets that, as he said, lead us to certain places where we want to be. And that's definitely a place where you can start to look at it. And the example dashboard I've got up here is one of those.
The other thing you can do is it would help. You can use it to justify the need for additional staff or additional programs looking at the information.
Yeah, we see that all of our people are over their caseload limits and things like that, and how we would use that to justify how we make different operational decisions. Exactly.
Yeah, managers just have a target of hours, and once you start going to OT, then you have that equal hour, then you know that, yeah, I need this. Or when you, yeah, definitely.
So they pop up in a number of different places that we see elsewhere as well. And I'm going to just kind of add these all in here. We've got our COVID dashboards. Many of you guys would have gotten used to looking at the COVID dashboard over the last couple of years. How many cases are in our community? How many things are we seeing? And I'm going to click over to that in just a minute. I'll pop over and share my screen in a couple of these online dashboards. So there's a DBHDS state dashboard that shows how we're doing on certain performance metrics as a CSB system and as individual CSBs. You guys caught on to a couple of these things: no-show reports, financial reports. We look at level of care assessments. We look at our ASAMs. We look at our Columbia suicide risk screeners, and we look at satisfaction surveys. These are all places where we see business informatics that help us make determinations about how we're operating. So I'm going to pull out of this one for just a second, and I'm going to bring us to the COVID dashboard just as a way to look at an example. And so these COVID-19 dashboards that were put out by the Virginia Department of Health were really important ways to communicate to the public and to business operators and to healthcare organizations, et cetera, how to prepare for surges in cases and other information. And so they were published by the Virginia Department of Health, and they helped you understand how much the spread was going on in the community. And so we had waves, right? And we all knew that waves mattered for how much maybe we wanted to expose ourselves in public, how much or how we monitored the folks coming in and out of our agency. And a lot of our COVID policy was shaped exactly off of the information that was reported here. And we all felt like that was some pretty important work that was shared publicly. We also have dashboards that are published by the Department of Behavioral Health, and these are around certain service metrics. So can everybody see this that says same day access measures? I want to make sure that tab showed up. I saw a couple of shakes. Good. And so DBHDS does this for us. And so we're supposed to have a measure of how many appointments are offered within 10 business days, right? Across the CSB system. That's a same day access measure. So after you've had your assessment, how many times do you have your next appointment within 10 days? And our target here, you can see, is 86%. And right now the CSB system as a whole is at 69.6%. Well, if I drill down and I look at Western Tidewater for FY22, you can see that we actually were at 98.5% there. And within the 30 calendar days, which was an appointments kept measure, we were at 98.3. So we were far exceeding what our measurement was for how we were supposed to deliver that. So we were in excess of what the average for the state was and in excess of what our target metric was. So these are just ways to measure the work that we do and report back to us so that we can take actionable steps. So if we were way low on this, say we were at 69% and our target was 86, we know we'd have to look at how do we either improve our workflow and efficiency, or how do we measure or how do we improve our capacity to be able to schedule those appointments more regularly. So what Stephanie brought up, do we need more clinicians available to take those appointments, those kinds of things.
So Brandon, can I jump in for just a second? Are those dashboards? Just want to let folks know that the Credible team has access to those dashboards. And our very own Shannon Saunders has taken the lead on this activity. She's going to be looking at those. She's coming up with a plan and a process on how to consume that data and push that data back out to you all so that we can make some meaningful decisions regarding it. So expect to see some fun stuff like that coming soon.
Exactly. All right. And Demetrius, I see dropped a note in the chat, that these are all, those metrics are all good support for when you go to ask for additional funds, right? If DBHDS knows we're doing what we're supposed to do with the money that they're giving us, then they're more likely to give us more money. It's the principle of, if you do a good job with a little, we'll give you some more. And that's an important, piece of understanding for how our metrics ultimately drive the performance of our CSB. So we're going to get into some more of these things and how we can use our informatics that are available to us to make better decisions internally. We're going to hit on each one of these a little bit as we go through. So the next slide we see on the left, how do we make some data useful? And then on the right, some no-show results. So these are the same exact representations of data that you see on this screen here. The one on the left is the stuff that our Rays and our Mitzies and our really detail-oriented finance people and all that are used to scrubbing through and making sense of. They can see the spreadsheet, they can see the list of services, and they can make a whole lot of sense of that. But it takes time and it takes attention to detail and it takes, a lot of energy. Sometimes we as managers don't always have the time to dive into that. And we say, I need a quick snapshot of something that kind of helps me focus on what's the low-hanging fruit. And so when you take that same information and you throw it into a picture, that's what you get on the right. It's the same data, but I can make a lot better determination on that look, I've got some no-show reasons. It's not just that they have a lot of no-shows, it's that there's a whole lot of no-shows that were canceled by the provider themselves. And that to me is more interesting information than just knowing they have a lot of no-shows. It means that they're the ones creating the no-show. So what's going on? Is Brandon's schedule too busy? And so he's getting pulled away from client care. Is Brandon lazy and he's just canceling the appointments because he doesn't want to do the session? Is Brandon running behind on his other sessions? So it gives me a way as a manager to think about Brandon's work and understand it in a really quick and easily consumable way because it's a picture format. And so a lot of what you have seen probably in growth from some of our BI reporting and things like that is that we have tried to get it into picture format to try to accompany row level results with more graphic representation, things like that. It's easier for our brains to work on. One of my favorite thoughts in meetings is I try to make sure I keep a box of crayons handy, because if I can draw a picture that represents what we're talking about, people usually understand it better than a whole lot of the words that I've got here. It's the same reason that you have a PowerPoint instead of just me talking to you today.
So I find it, Brandon, real quick, I find it very especially when we get back into the offices and stuff, you use big Post-it notes on the walls and you draw out your concepts. You can just, I've used it for 12 years. And I mean, just be careful not to scribble on the conference walls like I have before with Sharpies. But yeah, it's just, you draw out the whole concept, then you can start to see it. Then you can start to just visualize it and then bring it down to where you need it. And then you know the information you want to gather. Then you go in and go gather it. And that paints that picture.
Yeah, exactly. And I do have a quick tip. If you write on a whiteboard with a Sharpie, if you draw over it with a dry erase marker, you can actually get the Sharpie off of the dry erase board. Try it next time. All right. So we're going to talk about no-shows. And there's a lot of stuff that goes into no-shows. So I want you guys to start by telling me, what are some of your concerns about no-shows? What does it tell you about clinical treatment? What does it tell you about client performance? Some of those kind of things. Before I throw up the bullets on the screen, let's see how much you guys can think about that.
I think no-shows sometimes show that the client isn't getting what they need, or they don't value the service.
Yeah.
I think in addition to that, sometimes our clients just aren't prepared or not really ready for the service that they've committed to.
Client readiness, I like it.
Other times there's barriers, transportation. They don't have the online that they need, the minutes on their phone, whatever.
I think you can see patterns. So maybe they were stable at attending and then they stopped, and maybe that could be a trigger of our symptoms getting worse.
Yeah.
And this is Margot. I think sometimes their symptoms are improved and thereby they're like, well, I feel much better. I don't need to go any longer.
Yeah.
It has a financial impact too. So
yeah, absolutely. So I think you guys are spot on. All things that we know anecdotally that lead us, to worry about no-shows and what it can mean about clinical treatment, what it can mean about financial impacts, what it can mean about progress in treatment. And, we're in a counseling field. So, I love the quote from Brene Brown that I threw up here, that vulnerability is about showing up and being seen. It's tough to do that when we're terrified about what people might see or think. So when you think about a no-show around somebody that's struggling with a mental illness or an anxiety or things like that, we know that just showing up at the appointment could be a hard thing to do, and being willing to talk about that. And so these are things that all of our therapists should be keyed into, and we should be asking questions about when somebody doesn't show up. What is that vulnerability that they have, or what is the need that they have that this is displaying? So we've been trained to think about those no-shows in terms of the business impact, all the CURT stuff. I'll label that the CURT stuff. And how does that manage or impact productivity, money, scheduling? And those are what a lot of our no-show reports have been built around, right? Is to think about what that means for productivity. We want to have no-show rates under 30%. We want to make sure that we build enough services so that we can pay everybody. We want to make sure people's schedules are full, and maybe we do some double booking because we know we're going to get a certain percentage of no-shows. Those are the kind of things we focused on. But as all of you pointed out, they talk to us about clinical changes too. So maybe that shows a low engagement in treatment. That could be a relationship with the provider. It could be a fear. It could be, I don't have enough things to be able to get me to the appointment. And it can talk about that lack of readiness for change, right? And that, I'm not really ready to deal with some of these scars that have happened previously. Or maybe treatment's going too fast or too slow. I'm not ready to deal with those things, or I'm bored. I don't want to keep talking about this issue that I've had. So I think those are all important things for us to try to keep an eye on, and try to ensure that we have properly followed up. And I saw Trish drop in there that, maybe their crisis is resolved. So in a crisis thing, if they're not showing up anymore, maybe that crisis has resolved, or maybe that immediate issue that has been shared with us and the reason they sought treatment was resolved. And now we as clinicians may think, well, you haven't quite, gotten to the root of it. It's going to recur, right? So how do we keep the client engaged long enough to deal with some of the underlying issues, even if the precipitating event has been resolved and taken care of? Those are all challenges that we have as we go on.
There's definitely some sort of communication breakdown there that when a no-show happens, whether on the side of the client or the counselor, and that's kind of, we need to find, where did that happen? Did that basically happen because they felt like they were fine? But even there, if they felt like they were fine, there was no communication. There was nothing happening there.
Yeah, exactly. Yeah. And so, there's no matter what level of care you're providing, there's a relationship that occurs where you should be talking to one another if you need to cancel or if you need to reschedule or things like that. And so there's a clear communication breakdown if we end up in a no-show situation where somebody has canceled late or not shown up for the appointment at all.
And also it could be impacted by what the client is saying is the value of the visit. Am I really getting value out of this, in measuring that? And so, you would have to support that. Yes, this is the value, this is progress we're making. And that would help probably, reduce our no-shows.
What's in it for me? That's a question we should probably be asking ourselves a lot is, what does the client see as in it for them? And what are we seeing it as in it for us?
Brandon, I think it also speaks to setting the expectations. Sometimes their expectations aren't being met when they are engaged in services. For example, they may think for a mobile team, well, we're eventually going to remove that person from the home, right? So right up front, we need to explain what the objective is of the service and maybe even assist them in understanding the parallels of where they should, where they want to be at certain times and what is the real reality of, the measurement of their advancement in therapy.
Yeah, 100%. It's the what's in it for me, but my expectation, like why did I show up versus why Sheila thinks I'm actually sitting in her office. Yeah, 100%. And so when we start to look at those no-show reports that we bring out to people, it's not just about, the key is it's not just about what this means from a bottom line and what our metric is internally to get you down to a low no-show rate or what things are concerns. It's also about really how are we delivering that care and making sure that we understand that in a conceptual and maybe even aggregate framework about how the performance is. So let's take a look at no-shows by clinicians. And in this graph, you can see that we have 5 different clinicians all working in our unidentified department. And we see a breakdown of the total number of no-shows. So this could come out in an Excel spreadsheet and we'd have to go through and count and note line by line. But if we just drop it into a graph, it's pretty easy to see here. Who's the one with the most no-shows?
Clinician 1.
Clinician 1, exactly. So we'll call him Greg. So we're going to work on Greg today because Greg is not doing so well with his no-shows. And we want to probably dig a little deeper because I know Greg's a good guy. I've met him. I've known him for a while. I don't know why somebody wouldn't want to come in and see Greg. So we'll probably take a deep dive on him. Now, if you
Brandon,
yep.
This is Stephanie. Can I was thinking about that, looking at, canceled by provider and thinking that I have had some of those because the appointments were so far out that I was looking at them and I felt like they needed to be brought in sooner. So you really, when you're looking at data, you need to drill down and look at exactly why, because, if a clinician was doing that, I would think that would be a positive instead of a negative. So do you know what I mean? Like, we really need to drill down in the data, not just look at the surface. Oh, there's a lot of no-shows.
Yeah, you're 100% right, Stephanie. And this stuff can tell us what it can tell us. It's no substitute for actual supervision discussion with providers and understanding some of the cases better. And it also speaks to what categories should we be measuring a little differently? You know, how can we update the information we capture in an EHR to give us better granularity and better reasoning that we can look at? So and we're gonna dive into that in just a second. In fact, getting into a little bit more granular about, you know, Greg, our clinician one guy out here. So who here, if you were looking for somebody to talk to your program, would you pick to talk about some of the ways that they've decreased their no-shows, or at least maybe start to talk to see if they have any good ideas? See Kurt holding up 3 fingers, so I'm guessing he's either one.
Clinician 3.
Yeah. Clinician 3. They've only got 1 no-show. So that means 1 of 2 things to me, and this is to emphasize Stephanie's point. Either they're not documenting their services correctly and they have no-shows because they haven't been documenting the no-shows the way we ask them to, or they're really good at client engagement and their people are actively involved and they're doing a really great job. So it doesn't tell me everything, but that's the first person I'd start talking to just from a big picture view until I get down to a little bit lower level.
It could also mean, Brandon, that they are just not productive, right? So maybe they saw 2 clients, 1 no-show.
Yeah, really good. Exactly. You might not be seeing a whole lot of people, so your no-shows are not that high. So we know at least Greg's scheduling appointments, even if he doesn't see them. All right, so let's look at Greg a little bit here. Greg, thanks for being the guinea pig, by the way. And so this is the same graph we saw on that first slide, right? It's how many of these were canceled by provider, what's the late cancel, and what's the client no-show. And so by looking at this graph, what we see is that he's only got 3 late cancels. So that doesn't seem to be a huge deal. If his clients are going to cancel, they're going to, you know, generally do it okay. But we've got the cancel by provider thing that we would want to look at more, and we've got this client no-show, and they're pretty similar. They're both pretty big chunks of that pie, and we would want to dive deeper. So Stephanie already hit on this a little bit about what do I want to ask my Greg when I get him into supervision. What do we want to talk about? So, you know, we're going to say, Greg, look, you had 49 no-shows, and, you know, kind of here's a breakdown. Why don't we talk a little bit about this? What's going on? Any other specific questions beyond what we've already said that you'd want to ask and chat about with Greg?
The reason why he has so many that he canceled.
Sure.
What's going on with that?
Yep.
I might ask him to show me how he's doing the no-show notes, because he might be choosing the wrong thing.
Oh, that's a good one, Chiquita. Are
I
you
would-
are you
I'm sorry.
properly using the electronic health record? Do you need more training in how to code these things? And Sheila?
I would ask him what his initial rapport building steps are towards these clients.
Right. So what's your client engagement look like? And how are you starting to build that therapeutic alliance? Good. All right. So again, it's looking at the information that you've been presented and knowing that you can't just scrub it on the surface, but that it's going to trigger you to then ask more questions and do some more work on, all right, what's the biggest fire I have to put out here? And that can kind of help you move and progress through the things that are maybe the highest pressure points and move into some of the things that are lower pressure points as you go on and get more sophisticated with your approach. So in this, whoops, hit the button on my mouse, sorry. In that graphic on the left, we would probably check in with clinician 4 next and clinician 5. And so you're using these aggregate reports to get you down to a place where you can actually do supervision. And these are great things to look at with your staff as well, to say, hey, here's how you line up with some of the other people in our department. Here's what the information's telling us, and then they can help you make sense of the results. So really good work so far, guys. All right. So what if we're doing it to manage an entire caseload for somebody? So this was a further breakdown of clinician 1. So we're still looking at Greg's population, that same graph that we were on. And what we can see here is we can see how many no-shows did everybody have on Greg's caseload. And when we do that, we see that client ID, and we can obviously see that there's a few folks that are bigger outliers than others. So, you know, why does 96465 have a higher no-show rate maybe than 97303, and so on and so forth? And you can see that Greg's got a lot of people with one no-show, and you know that kind of stands out to me a little bit too. And so I'd want to ask questions about that, the coding, the work. Maybe the other thing is if it was the cancel by provider, did Greg take a week of sick leave and Greg had to take a week off, so we had to cancel by provider because he was out sick? And so how do we relate it back to other information that we have, say in Kronos, and sick leave and days off and things like that that would have come up? So those are all kind of some of the important questions. So I want to talk about and transition over to some more of our clinical information that we get on some of the standardized screening and tools that we use at the agency. So DLA 20 is a functional assessment that we use. And I dropped this quote in here from Seth Godin because I think it's important to know why we're measuring stuff. A useful metric is both accurate in that it measures what it says it measures, and it's aligned with goals. Don't measure anything unless data helps you make a better decision or a change in your actions. And so in a world filled with data, let's not measure the things that don't really matter or that we can't really apply to our practices. It just means that you spend more time measuring things that you'll never use. And that's a waste of all of our time. That's honestly one of the questions that we bring up regularly with our State Department of Behavioral Health. We talk to them about what metrics do you really need and what's most important in driving the system change. Also, once you've achieved a goal on a certain metric, maybe it's not time to focus on that metric anymore just because you've always measured it. Maybe it's time to transition to what is important for us to measure, and now that we've gotten past that hurdle.
Brandon, we always used a kind of a rule of thumb: if between a 90-95% threshold of the metric, then you find a new metric to measure, because your people are in the habit now and they know what they're looking for. And all these metrics, once again, should always be leading metrics too. Something you can analyze right as you watch the trend. You know, 1 day is an anomaly, 2 days is a hum, and a 3 day is a trend. So that's just, sorry to interject, but that's what you want to do with your metrics. And like I said, we always target at 95%, but whatever.
Yep. So let's take a look at what are some of the things we already know about DLA 20. It's designed as a functional assessment, captures 20 domain areas. It serves as the initial assessment in our system as one's areas of needs and strengths. Some change in scores over time can be used to assess progress in treatment with appropriate inter-rater reliability. So that's a big term, inter-rater reliability. All it means is that if Sheila scores a person on the DLA 20 and Brandon scores a person on the DLA 20 on the same day with the same kind of things going on, our scores should be very similar, or if not the same, right? And the further apart Sheila and Brandon's scores are for the same presentation, the lower the inter-rater reliability is. And try to say that 3 times fast, it'll trip you up every time, I promise. Change in scores over time may also reflect circumstantial changes that aren't related to treatment. So when we've talked about using DLA 20 as a metric in the state, one of the things that we focused on is, you know, there's things that impact what your DLA 20 scores are outside of treatment. So if Brandon enters treatment, maybe for substance abuse, and he does start to get things under control, he may drop in some of his social connectedness domains. He may drop in some areas around housing and things like that. As he moves away from things that used to be triggers to his substance use, we may see a decline that's not even related to treatment. Other things like loss of job, financial stressors, they could be unrelated to the treatment that the individual is receiving, but still a factor in how Brandon's functioning. So what do we look at here to improve our treatment? Knowing these 4 things, I want to open it up to you guys before I drop any bullets on the screen. So if you're looking at a DLA 20 or any kind of a functional assessment of somebody, what are some of the things that you would want to take a peek at to improve our treatment?
Are we, and I'm still kind of treading water on this myself, but are we basically looking at, are these no-shows just getting rescheduled and rescheduled and rescheduled? And at some point, there's a discharge process there, because are we just allowing it to keep happening?
Yeah, and so not necessarily DLA 20 related, but that's a good point to where we were, is that another thing when you're thinking about no-shows, are we enacting our principles for client engagement, right? Are we following our policy around client engagement and how we're supposed to try to circle back with somebody? All right, Simone and Brittany, I'm going to call you out. You got some stuff here in the chat. Go ahead, speak up to us.
They might need a higher level of care, so they're having a hard time with maybe like traditional outpatient services. But if you look at their DLA 20, maybe it indicates that they'd be better served by more wraparound services.
Sure.
I agree with Brittany. Also, just ensuring that DLAs are accurate, ensuring that they're up to date, and ensuring that you observe these behaviors as well, or collecting collateral information to complete, so they can get the right level of service needed for their care.
Yeah, so did we do a good job of capturing the whole picture of the client when we did the DLA 20 and making sure that we followed the procedures based on training on how to administer that? Good. All right. So some of those things that might pique our interest would be, what does the average change score look like for patients in our program? So if we're running mental health outpatients and we want to see, kind of the comprehensive picture of how well we're doing, what's the average change look like over that whole aggregate across clinicians and clients? Are there specific areas that we seem to be most impactful by providing treatment? So in those 20 domains, does mental health outpatient impact, domain 3 more than domain 7 and things like that? How does that look? Is the treatment we're providing designed to impact the weakest domains of the individuals we're treating? So this gets to, are we in the right level of care, right? The Brittany question of, is outpatient therapy designed to impact domain number 7 on the DLA 20, or are we really looking at domain number 3? What is the best assignment for that in particular client? So let's start to look at some of the results and see what kind of ideas we can derive from that. So this is a graphic representation of the average DLA 20 score change for 10 different clinicians in a single department. And I'll let you know, all this data is pulled directly out of Credible. So this is all information that we have and is dropped directly into a graph. It's real information, it's just been de-identified. And so when you look at this, you can see that we've got some folks that have some negative DLA 20s, got some folks that have some positive DLA 20 change scores. And so when you look at this graph, what are some questions that you ask?
Honestly, I want to know what number 2, clinician number 2 is doing.
Why is clinician number 2 doing so well?
This is a change in DLA 20.
Correct.
So am I reading this correctly? Where the bottom is the original part, if you would,
So yeah, well, that's a good question, Teresa, because this is a hard graph to read, and I tried to make this better. And this is the best representation I came up with. But if you see your 0 line here, which is what the horizontal bolded line is, that's your 0 line. And so anything that's below that in a clinician's column is a negative score, which means that their DLA 20, their functional ability has been assessed to decline. So their aggregate caseload, all of their caseload, their scores dropped as an aggregate. If it's above that line, if your bar is above that line, then the functional ability of your clients has been assessed to improve. And then just down here, this row, this just actually translates to what the actual delta score was. So you got the graphic representation up here, and then you've got the actual numbers down here.
Well, I would be looking at the main factors in your clinician 1, 3, and 9. Why is this decline have taken? And then once again, as was said, you've got to see what's this person doing right, and that would be clinician 2, and even 7 to an extent. But analyzing the root problems here, and it may be the same problems they're having, maybe their client base, maybe whatever. But obviously, clinician 2 is doing something very right, and clinician 7 is doing a pretty good job too.
The other factor could be intensity of diagnoses and how it cycles. So are we comparing apples to apples and oranges to oranges with these clinicians?
Yeah, and so that's the tricky part, right? That we get into for assessing on aggregate levels like this. Does clinician 9 have a really difficult caseload? Some comments in the chat were, what's the caseload size look like? Is it different for clinician 9 versus clinician 2? So those are all questions I'd want to answer. Is it the same person rating? And when we look at it, do we know that clinician 2 is good at doing the DLA 20 assessment, or are they just trying to make themselves look good? So maybe we want to understand, did they do a good job with treatment, or did they do a good job of making their test results look different?
Does clinician 2 perhaps have a less acute caseload?
Correct. And that's another thing that DLA 20 can be really tricky on as well, because actually, when you have a relatively high functioning caseload to start off with, to achieve any true gains in functional ability, you reach a certain point where you plateau, right? Because most of us would all have areas in the 20 domains that we would be a little lower on than others. So you don't ever really achieve this like perfect scale. And so maybe they've got a less acute caseload that you just can't make much clinical gain in because they've kind of plateaued. Maybe it's time for them to come out of services. So a couple of things, what does it tell us about the clinician and their efficacy? We've talked about that. What information doesn't the chart provide that would be useful to know? So we've hit on caseload size. We've hit on, is it the same person doing the rating, or is it different people doing a rating across that same person's caseload? Anything else that it doesn't show that we would want to know?
Diagnosis.
Diagnosis, yep.
Because you have some populations, like if you're working with substance use disorders, the relapse rates tend to be pretty high, which impacts a lot of those other DL 20 domains.
And then the drill down question. If you were supervising clinician number 9, who just happens to be the target person here today that has the lowest DLA 20 score change, or the most negative DLA 20 score change, how would you use that chart to discuss their work? And I think we've touched on that, right? We would start to ask questions like, well, what does your caseload look like? How many cases are you managing? What is the diagnostic profile of most of your cases? What else would you want to start to ask that clinician?
I would want to know modalities used. Does it pair with or align with that person's abilities? You can speak way over someone's head, or, apply certain strategies that are inappropriate for that person's advancement.
Yeah, right. So, if Sheila's speaking to me and she uses words and strategies that are just beyond my functional level, period, probably not going to see the kind of results we're looking for. Even if she's really providing, solid evidence-based work, it may not be the right evidence base to use with that person, or she may need a different approach. Good. All right, so let's talk a little bit about comparing some programs and what we can see and what we can't see by looking at this. So these are things you guys brought up, right? Acuity level and treatment strategies and all of that. So, well, let's look at DLA 20 by two different programs. We've got PACT MH and MHOP. Well, crud, when I pull the data, you know what it shows me? They both had a negative 0.06 aggregate DLA 20 score change. So across all the patients in both of those programs, that's what we found. Well, that's kind of, not going to help me out a whole lot, is it? And I'll share with you guys, I think I only pulled a couple of clinicians from each program when we put this together. I didn't actually do the full program. But looking at at clinicians from each program, this is what it looked like. So how does that chart help us differentiate between the two programs? Simple answer, it doesn't, right? I can't tell anything different about MHOP or PACT from this chart than anything else. So what questions does it bring to mind about the programmatic performance? And what else do you want to know? So I have a lot of questions when I look at this. Well, why are our programs both showing negative scores? We might want to take a look at that. There might be some really legitimate reasons. Maybe this was pulled right at the beginning of the COVID-19 pandemic. And so maybe everybody's functional assessments went down a little bit because of all the stressors in life. Maybe this shows that we've had a lot of vacancies in both programs, and we'd be concerned about that and how that's impacting care. So any other questions about DLA 20 before I move on? Because we're gonna jump over to Columbia Suicide Rating Scale. But just anything else that stands out to you around DLA 20 performance and how you might start to use some of the information there to impact your assessment as managers. Justina brought up a good one in the chat. Come on, Justina, come off mute.
Okay. I said that sometimes clients will wait to disclose things to the clinician versus what they say in assessment. And so when the clinician goes back to do their DLA 20, then it'll drop the score.
Right. So as we find out more information to do a better rating, then sometimes that reflects a negative change, even though the client may be functioning at the same or maybe even a better level than they were at intake. Yeah, very good. And Angela, she agreed with Justina, but you have another good point. So come on, Angela, join the party.
No, I was just saying, just from personal experience, a lot of providers, will come in, the client may have questions, but the provider's not listening. So therefore the client doesn't get to explain everything. It could be they don't connect with the provider, or like what Justina said, that, they just forget to disclose any information, some of that information in the beginning.
Yeah, absolutely. All right, you guys are rock stars at this, by the way. You're doing really good, so keep up the good work. All right, so Columbia Suicide Severity Rating Scale, or the CSSRS. And so we collect this on every veteran or service member or their family member that comes in, and try to collect it, I think, on all intakes. And we think about this a lot with our veteran services, and it's because suicide rates are so high amongst our veteran community. And let's talk a little bit about, what do we know about the Columbia Suicide Severity Rating Scale? It's a point in time, so it doesn't reflect a long duration of care. You're taking it as a point in time, and that's the assessment of the person at that moment. And it helps to guide clinical intervention for suicidality. So how are we going to bring that person into some crisis care, and what do we need to focus on to start with? They might change over time due to treatment and non-treatment related circumstances. So a lot like the DLA-20, that there could be changes that are completely related to treatment and completely unrelated. For instance, if Brandon is assessed at intake, and maybe a year later, Brandon's marriage has fallen apart, my CSSRS may change, not as a result of the treatment I got, but maybe as a result of what's going on in my home life and my personal life. A good clinical interview already answers the majority of your CSSRS questions. So while it's a form we fill out, when you're doing a good clinical interview and asking about certain things, you're going to find out the suicide risk. So we're asking questions like, have you ever had thoughts about suicide? And those things are going to come up in your clinical inventory. So what can we learn? What's the expected risk profile for individuals in our program? So is it a different risk profile for people that are enrolled in mental health outpatient versus substance abuse outpatient? Is there a different risk profile for suicidality there, or is it similar? Where do we need to strengthen our training and safety planning? So if I pulled this and I saw 75% of clients in PACT were at a moderate or a high risk for suicide based off the CSSRS, maybe we need to do more safety planning training and growth there in that program, because they're going to see a high percentage of patients that are suicidal. Are there any unknown risks in certain populations? So for instance, veterans and others. Any other questions that you think we could learn from taking a peek at Columbia Business Informatics? All right, I promise we're just about to the end. So you guys, I don't see anybody's eyes rolling yet, but I only see 5 of you on the screen. So we're doing okay. I promise we're going to make it to the end. So let's look at a CSSRS rating scale for a specific program. This is just a snapshot of the last Columbia that was done for individuals in a given program and what their risk level was. So we've got 48% that had no risk. So they were rated as no risk. There were no yeses on that Columbia suicide rating scale. We've got a 25% grouping. So 1/4 of the clients in that program had a low risk for suicide. There was 14% that had a moderate risk and 13% that had a high risk. So if you were to just guess without knowing which program this was, what kind of a treatment program do you think this would be? Do you think it's
outpatient? Outpatient.
Outpatient. Okay. And how come, Sheila?
Because if there was the population that probably had a higher percentage of none, it would be a less restrictive program.
Right. Any other conclusions that you would draw from looking at this graph without any more information? Or this pie chart? What type of training would you recommend for a program with that kind of a patient risk profile? What kind of training would you make sure that staff gets by just looking at this information?
Harm reduction.
Harm reduction? Okay. How come,
Trauma
Trish?
training.
I missed who went after Trish. I'm sorry.
Trauma training.
Trauma training. Good. How come, Teresa?
Well, because just looking at the graph, first of all, 48%, that's really good in the moment in time that the snapshot. But because of life situations and especially so many people do have trauma and how they can be triggered, person in the 48th percentile could move very quickly to the 13th percentile. And to be able to just have a clinician who's able to understand the trigger, what triggers are and what triggers can happen and how to help their clients develop coping skills and strategies and how to work with trauma and have the education about trauma and how it affects them is going to give you a better outcome.
Great. So Teresa's taken what she knows about clinical treatment, applied that to a simple graphic representation, and allowed that to help her focus in on what would I train my staff to do as a result of the presentation that I see here and what I might expect to see in that caseload. And she didn't even need to know what program she was talking about. This could have been outpatient. It could have been a PACT program. It could have been case management. And those would have applied equally well no matter what. And Darylyn's hiding behind the chat. Darylyn, come on off mute.
I just mentioned some crisis management, de-escalation training, just to be able to process some of those SI presentations.
Yeah, very good.
We were talking about earlier about how the outpatient programs tend to be considered to be lower risk because they're at that lower level of care. But I guess I would also interest in training on SEPs and RAP plans for those who have higher levels of care, because sometimes patients get exhausted from seeing so many paid providers. Maybe seeing less intensive providers will be helpful and supportive in the risk management.
Well, keep in mind also that some folks may be in a program like outpatient because that's a program they first get assessed for and come into, but their needs may change over time, or as we work with them, we discover that there's additional risk factors.
Yeah. And Rachel, that proactive approach, meaning that somebody doesn't have to come to a crisis service to get something like a RAP plan or a SEP, but we can start to think about that. And so that leads into this next question really well of what resources do you want to make available to those with the highest risk, and how much staff time should be dedicated to those resources. So again, you're managing scarce resources. And if you know you've got a higher risk part of your population, how do you move staff time or resources around in your program to meet those needs? Oops, went the wrong way, sorry. And then finally, who would you routinely want to consult with in your agency if you oversaw this program?
The patient. I would say the clients who go through this process to see what was their experience and what they needed more of, or to see what's working.
So some client satisfaction surveying and client growth surveying. Good. I'd probably want to make sure that my staff all knew, where Rachel's crisis receiving center was, so they could talk to patients about that. I'd probably want to make sure that they were aware of our crisis lines of our emergency services department and when to contact each one of those, right? That would be a good understanding. If you've got more than half of your caseload that has some risk for suicidality, then you want to make sure that your staff are properly educated to support them with those risks and things that pop up. Good. All right. Now we're going to transition to what everybody's really excited for, at least Kurt is. We're going to talk about billing and time management informatics. And these matter for us because the better job we do with billing, the better job we do with time management in our staff, the greater capacity for care we have to deliver, the greater opportunity we have to reach people and deliver more care to them. There's never enough time to do everything, but there's always enough time to do the most important thing. And so how do you prioritize those scarce resources? And I honestly, I was thinking about Kurt when I put this other little graphic up here. And I said, if you don't have paying customers, then you don't have a job, you have a hobby. And so while many of us that have our clinicians at heart, our social workers at heart, things like that, we want to save the world. However, you have to sometimes ask about the payment piece, because if not, then we really don't have a job here, and I can't afford to pay all the staff that we need to have to serve that population. So looking at that revenue is one of the keys to a balanced budget. You monitor your expenses, but you've also got to manage your revenue. Efficient use of staff time increases revenue without increasing their burden. So what are the tasks I'm sending people off to? If I have a case manager that does nothing more than provide taxi service, then am I maximizing what's going on for that case manager? Or could I prioritize their time to working with the clients on other care navigation and coordination topics, and then have an aide that helps get them to where they're going, or get them a bus pass, or get them an Uber ride, or get them Medicaid taxi? Understanding the correlation between staff time and revenue also helps us make better business decisions. So if I know that my staff have to dedicate 4 hours a day to billable activities to meet my budget, then I know how I can make better business decisions about what I encourage them to do, how many staff I need, etc. So what do you guys like about measuring time? It's everybody's favorite topic. When you're measuring time and use of time and all those things, what do you like about measuring time?
I'm guessing most people don't.
There's got to be somebody out there.
Finding out what your productivity is.
Yeah, finding out what your productivity is.
Finding out the dollar value of that minute.
Do you guys think about your time in terms of what it costs the agency per minute for you to be doing a task or hour? And, you know, I don't dwell on those kind of things just honestly myself, but it does come down to, do I want Trish to spend an hour doing a restoration case, or do I want Trish to spend an hour doing a pre-admission screening? Which one is more important, both from a strategic planning point of view and from a productivity and dollars and cents point of view? What do you like about measuring money?
Well, I was just about to say, Brandon, I like measuring time to, and I think it connects to the second bullet point, because it helps me to better advocate for staff. Because if I see them spending a lot of time on a task that it was previously more than what they had been doing, then I can advocate for their salary to match if I need to.
Additional job duties and things like that that impact how we should compensate them. Good.
I think if staff know how much it costs to provide a service, I think that they, I mean, just when I learned, that when MTM came through and we learned how much it costs to do a service, that was a real eye opener for me. And sharing that with staff, I think they became more aware that, I need to increase my productivity. This is costing the agency a lot of money. And I think they valued more what they do. So I think it'd be helpful for both administrators and line staff.
There's a good, and some of the people on here have seen it, but just do a thing with their staff. What does 15 minutes cost a year? And figure out, everybody, probably has 15 minutes of non-productive time, and actually the number is about 5 hours and 20 some minutes a day is productive. And do 15 minutes and just do the numbers out. If you have any questions, you can call me. I can give you the screen. But it will blow you away, and it will blow your employees away. They'll just like, you gotta be kidding me. That's what it's costing. And all that can go into other benefits. It can go into more employees. It can go into better patient care. I mean, that's one of the things being tasked right now is how can we get more volunteer time out? But we have to pay for that somehow or another. So I'm done.
Good. Yeah, and so, then there's the opposite questions, and I'm not going to dwell on those. What don't we like about measuring time, and what don't we like about measuring money? Well, it feels like it's not as nice as talking about client care. It feels like we're holding somebody under our finger to try to pressure them to get more and all those kind of things. Those all feel not as good as some of those other metrics that we might look at, but they're all necessary pieces to know that, as Kurt said, if there's 15 minutes of time a day. What does that add up to in a week, in a month, in a year? And really, what does 15 minutes look like? You know, if I just have to be 15 minutes more productive per day, there's a lot of time there that can be changed. And what if we're asking for more than 15 minutes every single day from somebody that doesn't really have it to give? So they're overwhelmed with 15 minutes more work than they can do. And because of that, their clinical treatment falls off. So if we looked at these graphs here, same kind of questions we've been walking through everywhere, right? We look at the average amount billed per employee. Where would you start, you know, talking? Well, you know, I would probably start talking to employee number 4 and employee number 9 because they don't have any billing. So, you know, it's a pretty easy question to look at. And the informatic here helps us make those decisions like that, right? I don't have to comb through a spreadsheet or anything else. I can see employee 4 and 9 have no billing. Now, what I need to know is, what if employee 4 is my support staff? They might not supposed to be bringing any billing in, or if they're my case management aide that's there to support other people so they can do the billing. I need to know those things naturally about who my employees are, but I know where to focus. I can also look at employee number 8 and say, employee number 8's a rock star. You know, they're almost $200 over whatever employee 1 is, who's my next highest biller. Why are they doing so good? And is that increasing stress? Is it above what I would normally project? And then we hit our last one, which is average number of hours per day. You know, how productive are they? This gets into the 15 minutes. And what, you know, I can see here is, you know, employee 8, 7, 4, and 1, they're all, you know, pretty much close to the same number of productive hours that are tied to a client. That's how we talk about that in Western Tidewater language, right? It's time tied to a client, the number of hours per day we might put into the EHR. But we have employees 6 and 9 who are pretty low in comparison. And then you can take the two charts together and you can start to make some assumptions. Employee 8 has the most number of hours documented per day and the most billing revenue. That seems to correlate pretty well. Well, employee number 4, though, second most hours per day, but no billing. So what is going on with employee number 4? What kind of work are they doing? So I've told you a couple of the things I think are important about these two graphs. Anything that stands out to you that I didn't cover?
I would, in the case of, you know, the composition of one of our teams, for example, a hospital liaison, that role may encompass the 5 hours for number 4, but the assessments may be fewer that are billable for that particular role.
Yeah, because they may be doing work with people that are in a hospital that you can't bill for while you're doing the assessment. Good point, Sheila.